Thanks very much, Dr. Wilson, for speaking with us about your career in family medicine and your career in family medicine research. How did you become interested in medicine, first of all?
Oh, that's a good question. In medicine, I was doing very well in school in Owen Sound. And in high school, I wasn't really sure where I should be going with my life. And my aunt said, well, I think with your marks, you should apply to medical school. So I knew nothing about medicine. So I applied to pre-med, University of Toronto, and I graduated in '64, University of Toronto. And actually became interested in preventive medicine and graduated with honors, winning the prize from the Ontario Medical Association in preventive medicine.
Wow.
So that has always been sort of my area of interest, as well as clinical care.
Okay. And did you practice mainly in Hamilton?
I practiced for a short period of time. Actually, the Royal Canadian Air Force subsidized my education. And so when I graduated, I was a resident in internal medicine at the National Defence Medical Centre in Ottawa.
Oh, okay.
And when I was finished there, I went into practice for a short period in Ottawa and began to accept family medicine residents into my practice. And in 1974, McMaster University and actually Toronto Western Hospital and Ottawa Civic Hospital all asked me if I'd be interested in leaving family practice and coming and joining the faculty. So I had a choice, and I chose McMaster.
Okay. So you just mentioned preventive medicine.
Yes.
I understand much of your research was centered in preventive
Yes.
studies. How did you become interested in research from practice?
That's a good question too, because I really didn't see myself as a researcher when I joined the faculty in 1976. I was told by the dean that if I wanted to be promoted, if I wanted to have tenure, that I must publish. It was the publish or perish. So I wrote a couple of articles for the Canadian Family Physician, actually which were on counseling and communication between the family physician and the patient. And during that period of time, one of my residents, family medicine residents at McMaster, was seeing a patient. The patient happened to have pain in the chest. And the resident asked the patient a number of questions that were appropriate, cough and nausea and other factors, and asked the patient if he was a smoker. And the patient said yes, and the resident went on to ask other questions and then to do an examination, and came back out, and we talked about his interview, which was excellent, except for the fact that I said, well, he told you he was a smoker, and you didn't do anything with that information. And the resident said, well, and this was in 1979, I don't think doctors really have a responsibility in this area of smoking, because that's a personal choice, it's a lifestyle behavior. It's like anything else that a person chooses to do. Yeah, we know it's bad for them, but he didn't see physicians necessarily as having a role. So we talked about that, and we reviewed the literature. And there was actually one small study at that time in the UK by Michael Russell. And if I'm going on too long, just stop me.
That's okay.
Michael Russell was finding that among patients who were smokers, that just simple advice actually led to a 5% quit rate.
Mm-hmm.
So I thought, well, we can do better than that, because in other areas like hypertension and diabetes, we provide more than advice. We actually follow our patients. And we have never done that with smokers.
Okay.
So we decided that that's what we would do. We would, first of all, ask, are you a smoker? Mm-hmm. And 25% of our patients were. And then to advise them to stop smoking with our help, and then to follow them up. And our colleagues wondered if that really was going to make a difference. And so that's really what stimulated my interest in doing some research and studying that. And I was very, very fortunate because we had some, at McMaster at that time, some professional researchers. Professor Dave Sackett was a leading international research, and we went to his office and we said, look, we've got this question, can you help us? And he said, well, first of all, if you're going to answer that question, it's got to be a prospective, randomized, controlled clinical trial of clinical significance. And of course, I really didn't know much about what that meant, but he helped us to design an RCT, and we then got our colleagues. That was a big thing, to get our colleagues and reception staff, the nurse practitioners, all of the residents and medical students to cooperate in a study where we would ask everyone to ask the patient, no matter what they came in for, are you a smoker? Mm-hmm. And so because it was a controlled study, the receptionist actually put a card on the chart as to whether they were in the control group or the experimental group.
Okay.
And those smokers in the experimental group got advice plus the offer of follow-up. Those in the control group just got the advice. We would advise you to stop smoking. And we followed the patients for almost a year. Mm-hmm. Dr. Sackett said that we can't just from smokers accept a yes or no, and when you ask them, are you still smoking, we must ask them if they would submit themselves to a little carbon monoxide validation test. So we had them blow into a carbon monoxide meter. And we found, actually, we had a research assistant and we had some funds from the Lung Association because the Lung Association was interested. They gave us a couple of $1,000, and we borrowed a research assistant from CE&B. And we found at the end of 9 months that twice as many of the smokers in the experimental group, those who got the follow-up, had stopped smoking and had stayed stopped and had carbon monoxide levels of 0 to 7, which is normal, twice as many as those who didn't get the follow-up visit. So that was interesting for us. We we'd found out that it does make a difference. So we put together a manuscript, again with Dr. Sackett's help and his research assistant's help, and we actually sought the help of anybody who knew how to write a research paper because I didn't. But we put together a first draft and had their input and submitted it to the Canadian Medical Association Journal, and it was published. And that was, I guess, a turning point in my career because the CMAJ was peer-reviewed and had international scope. So we were getting calls then from quite a number of people, including the National Cancer Institute in the U.S. and the National Institute of Health, wow. The Lung Association, the Heart and Stroke Foundation, who were interested in more of this physician intervention in smoking cessation. And so we actually, I was able to put together a team with a number of physicians, non-physicians, scientists, and the lead in this was Alan Best at the University of Waterloo, who was chair of health promotion, who was a researcher and who was extremely instrumental in putting together a grant proposal that went to the National Cancer Institute in the U.S. And we were awarded $1.1 million, which blew my mind because I was going to be taking the lead and I would be writing the paper, which was eventually submitted to JAMA, the Journal of the American Medical Association. In the meantime, I thought I'd better learn something about research, so I took a course in design methods and evaluation at McMaster University, and that was very helpful. This study was a huge 3-group design where we actually randomized physicians into one of 3 groups.
Okay. So
the rest is history as far as smoking cessation is concerned.
Were you still practicing at that time?
Oh, yes. And that, I think, is a key to researchers who are wanting to submit grant proposals, is to be able to combine practice and teaching with doing research, as long as you have the support of your colleagues and the support of your chair, or your supervisor, whoever is responsible for your career.
Mm-hmm.
The other interesting thing that happened around that time was I was invited to join the faculty at a university medical school in the southern United States, and that was partly because of my publication. And so I said on the phone, I don't really think I want to move, but they said, well, look, we'd like to fly you and your wife down and put you up in the Hilton and wine and dine you, and you can speak to our faculty. And so I accepted. It was a nice place to go. And on the plane on the way down, I thought, now what am I going to speak about? And I thought, well, my interest is in disease prevention. It's in health promotion. So I would like to talk about that. And I'd like to talk about the lifestyle factors that we all have control over that may affect our morbidity,
okay,
our quality of life, our premature mortality. And these would be physical, emotional, and social lifestyle factors. So I started writing them down on the plane, and I thought, I don't really think I'll take notes, because I think I'd like them to know that this is all in my head. So I wrote down physical activity and nutrition and tobacco and alcohol and stress and family relationships and insight into our thoughts and behavior and career satisfaction. And I came up with a little mnemonic that was called FANTASTIC, F-A-N-T-A-S-T-I-C.
Wow.
Family and friends, activity, nutrition, tobacco, insight, stress, sleep belts, type of personality, insight, and career.
Okay.
And so I thought, well, that's an easy way to remember this. And I could talk about each of those factors in detail. And then we created an instrument called the Fantastic Lifestyle Self-Assessment, which is actually still in use today, and I'm still getting requests from all over the world to use this because it has a copyright on it.
Right.
A colleague of mine put it into an interactive Apple program in the early 80s when people didn't have computers, but the Ministry of Health in Ontario got hold of that. They used it at the Canadian National Exhibition. And we were told that it had face validity because we sent it out to several of our colleagues in various departments and universities, and that all of these, to them, were valid in terms of lifestyle factors which could be modified, that could affect physical, emotional, or social, that were physical, emotional, social factors that could affect morbidity or premature death. And so that really was a face validity type of research, and I thought we should really test its reliability as well. And again, asked my gurus in CE and B, which is clinical epidemiology and biostatistics, what they would do to test the reliability of it. And they suggested a retest reliability, which is where patients would complete it, they would come back in 2 weeks, complete it again, and look at the correlation coefficients of retest, and it had very high retest reliability, and that was a relatively easy study to do without any funding. But it's one that I think when people develop instruments for patient use or even for physicians, that it's probably worthwhile doing that type of study.
Mm-hmm. So it's being used still today.
Still being used, yes.
And what is it physicians do with the information then?
Well, physicians can actually take the form, put it in the chart, have the patient complete it, put in the chart. But it's actually being used outside physicians' offices more than in physicians' offices.
Okay.
It's being used in health clubs. It's being used in some medical schools in Australia and other parts of Europe to look at lifestyle factors among medical students before and after, and the same with nurses, and participation, for instance, included in their program. So it's an easy self-assessment tool. It takes about 5 minutes, gives you a score, and helps you to look at lifestyle areas that you can modify, that you can take control of.
Okay. Have you ever done any follow-up studies on the use of the Fantastic tool and the outcomes?
We actually were challenged by the College of Family Physicians in the early 80s to do some follow-up with it, to do some studies on populations, and then to submit. They wanted a series of 6 articles, which were all published in the Canadian Family Physician on fantastic. We did a Halton population survey with the fantastic instrument, and were able to compare that to one that was done in an area in Waterloo, and we were able to look at various populations, including university students, and we were able to look at some of the factors that were socioeconomic, and recognizing that those who were better off socioeconomically had better lifestyles, and that was a correlation that probably has been studied by other people, but it's unfortunate because I think a lot of the socioeconomically disadvantaged people can't afford the nutrition that costs money and can't afford the activities that some of the better off people can. There are a lot of studies still that need to be done to actually establish proof that the lifestyle factors, even though it's intuitive, for instance, the first one, family and friends, your communication with them, the relationships that you have, it's intuitive that these are going to affect emotional health and affecting physical health. And there have been some small studies which have demonstrated that, but it's an area, I think, in family relationships and communication within families and so on that probably needs even more study.
Okay. So I understand also that you have studied problem drinking and alcohol abuse, and you were the chairperson of the College of Family Physicians of Canada's Alcohol Risk Assessment and Intervention Committee. So tell me about that project.
Well, that was interesting too, and it was partly again because of my interest in lifestyle factors.
Okay.
The college, in I think the late 90s, was actually approached by the Brewers Association of Canada and offered some funds to the College of Family Physicians to look at, I think, what they were calling problem drinking. And we, Reg Perkin actually was the executive director of the college at the time, and we sat down with members of the Brewers Association. We actually put together a team of family physicians from across Canada and some addiction specialists from KMH here in Toronto, which was ARF at that time.
Right.
And we decided that rather than using the term problem drinking, and we debated that back and forth, it's still a reasonably good term, but it's hard to describe. We would call it at-risk drinking, to look at what actually a person's drinking behavior was that put them at risk.
Okay.
And there would be many factors. So we used established instruments such as the cage, for instance, which is still used. That's CAGE.
Okay.
C is, have you ever thought that you should cut down on your drinking? And the G is, have you felt guilty about your drinking? And the E is, have you had an early morning drink? The A that I skipped over is, have you been annoyed that other people have talked to you about your drinking? So that was part of it. But also looking at the numbers of drinks that they reported per day, the numbers per week. And again, in collaboration with people at ARF, and these some of these were family physicians as well, like Lynn Wilson and Mel Kahan. We, in reviewing the literature, felt comfortable at that time in setting limits that beyond those limits created problems. And there would be other situations where it would create problems as well. And we looked at pregnancy, for instance, as one. We looked at the literature on breast cancer was just coming in at the time in the association with drinking. So we thought that the limits for women should be lower than for men. And that was based on our critical review of the literature. We developed at that time what we called the 0, 3, 4, 12 formula, which actually has been modified since then. And 0 means that for many people, including underage people and pregnant women and people who are driving, the consumption is 0. And that for men, they should never exceed 3 drinks a day. Women should never exceed 3 drinks a day. Men should never exceed 4, and neither should exceed 12 drinks a week. Those limits have come down since that time, and actually for women it's now 9. And that's based on the association, the relationship between consumption, the dosage of alcohol, and other diseases, because the research is ongoing in terms of alcohol diseases, motor vehicle accidents, and so on.
Okay. What was the most rewarding aspect of your work?
I think the most rewarding aspect was the development of smoking cessation clinics that were based on the model that we had tested. Not only in my area, but across Canada and across the U.S. I was invited by the National Institute of Health in Bethesda to help them to put together a teaching program. I was invited by the American Academy of Family Physicians to put together a teaching program for physicians to use, and I was actually invited to several annual Academy state chapter meetings to present this work. But I think that the smoking cessation clinics that we established right at McMaster at the Family Practice Clinic, and then at the St. Joseph's Community Health Center, the Halton Health Department, which I just retired from last year, and that is still going, that smoking cessation clinic, and it's a good model. It's actually run by nurses now, public health nurses, nurse practitioners, and nurses do an excellent job at this sort of thing. They seem to have a better understanding of the problems of quitting smoking. Another rewarding area was at the Hamilton General Cardiac Ward, where I was invited to meet with all of the patients who had just recently had a myocardial infarction or had had coronary artery bypass surgery. And while they were in hospital, which is a very vulnerable time, to discuss with them the relationship of smoking to their heart and how actually stopping smoking can help, along with the medication, along with the other treatment, to reverse their disease. And stopping smoking does reverse disease, and I think a lot of smokers don't have that clear understanding, and they think it's too late. I've smoked for too many years now, and it will actually start reversing the disease as shown on coronary angiograms.
Really?
Yeah.
Wow, that's great stuff. What were the challenges for you in you were practicing, you were doing research, you had a family?
Yes.
And
yes.
what were the biggest challenges for you throughout your career in terms of the research, getting the research done? I know that's a really challenging part for some.
Yeah, and I think honestly, I was really lucky. I had tremendous support from my chair, Carl Moore, Walt Rosser, and Cheryl Levitt. Without that support, I think it would be a challenge to be able to practice medicine, to teach medical students and residents, to do some administration, and then also add research onto that. So all of them gave me freed up time for my research, and it started at 1 half day a week, 2 half days a week, and then about 4 half days a week, totally dedicated to research. The other, I think, way that I was lucky was in having at McMaster people who had been doing research who were able to teach me, because again, most family physicians really don't have the education on conducting research trials.
Right.
And they made it fun. And so that would have been a challenge for me had I not had that access.
Right.
The only small challenge might have been when I had a teaching practice with residents and a nurse practitioner and I was invited to meetings throughout the country and actually across the world, and somebody had to look after my patients and my practice. And so that was a challenge. I think some of the players raised options for me, one of which is to slow down as far as the research is concerned. But it's difficult to be full-time and to totally balance all four areas of service and administration, education, and research. So support of the colleagues and support by team members. And speaking of team members, I think creating a team always was helpful for me. And fortunately, we were able to get the funds to hire a project coordinator. And the project coordinator was able to sit with me and our team, and I didn't have to write the many pages for the grant proposal because she was able to listen to our issues, argue with us, and that was always fun, to come up with a grant proposal that looked like it was going to be a winner.
Okay. So as an individual researcher, you face challenges. As a discipline, research has faced challenges. Some of the most difficult things have been getting funding and getting acceptance from those who are making the decisions and who are handing out the money. What does the discipline of family medicine research have to do to be recognized and to get a hold of the funds that are out there? What are some of the most important things?
Yeah, that's a good question. And fortunately, we have people like Janusz Kasharowski, who was the lead speaker this morning, who was actually in our department of family medicine, hired by Cheryl Levitt. And that type of researcher, I think, can facilitate among the family physicians who are interested in research by mentoring, by making time available for one-on-one tutorials and that sort of thing. So I think that needing that expertise, and it's difficult, I think, for physicians practicing in isolated areas, but we do have Skype available now, and I think that some of the established family medicine researchers, whether they're physicians or whether they're PhD scientists or whether they're research assistants, would make themselves available to the budding researcher and would help them with the grant proposal. I think I was also very fortunate to know that there were a number of funding agencies interested in my area of research in the 80s and 90s. A lot of those dried up, I think, in the new millennium. And the CIHR process is very competitive. I think a family physician who is interested in research just has to recognize that he or she needs to be educated, to be supported, to not feel that he or she has to write the grant proposal, but to sit with somebody or Skype with somebody who has done it.
Okay.
And to try to get a small amount of funds, actually, to compensate that person with the grant proposal.
Okay. What advice would you give to a new researcher or somebody who's interested in exploring family medicine research or primary care research as a career?
As a career? Wow. I think as a career, family medicine, the way it's structured at the present time, hasn't really put together a supportive way of having someone who is a family physician make it a full career. I think it has to complement the practice of family medicine and education and probably some administration. But someone, a family physician who is interested in starting in research, I think creating a clinical question, And with me, most of my clinical questions came from my students, came from my residents, and and when they would ask a question like, how do we know, that, for instance, eating meat and potatoes is not necessarily the healthiest way for us. My challenge would be to them to review the literature, and let's talk about that. And the literature is a lot easier to review now than it was before computers 30 years ago.
Okay.
Yeah, it's so that we can assume that nutrition, plays a big role, and most of that research may not have been done by family physicians. It's probably done by allied health professionals. Mm-hmm. So that person who wants to study that, I think would probably meet with nutritionists, if that's the particular area, meet with those who are experts in the content area, meet with researchers, and I think that there may be some hesitation sometimes to do that, but I think what I found is that generally speaking, health professionals, particularly those who have done research, are keen and they're anxious to mentor and tutor someone who wants to go along that pathway. So the collaboration, the seeking out of expertise, finding someone who is good at putting a grant proposal together. You can do the first draft, but then just find someone who has done this before. Mm-hmm. And I'm not sure if the college, I've been retired for a bit, has established that process, but that I think would be useful for college members to know that there are researchers, or there is a mechanism within the College of Family Physicians that is going to help me get started, that is going to help me put together a grant proposal, that is going to help me with the design, with the methods, and with the evaluation.
So a lot of collaboration helps.
Yeah, you can't do it alone.
Yeah. What will be the big questions for family medicine research, primary care researchers in the next decade or two?
Oh, I think there's a lot of quality research, qualitative research that needs to be done. I attended one of the sessions this morning on pain, for instance. Mm-hmm. We need to have a better understanding of our patients who are in chronic pain because they look well. That's a problem. So we need to have the instruments and the clinical expertise to get a good understanding of someone with pain. The other session I attended just after that was on spirituality, done by a young assistant professor from McMaster University, who is looking at religion/spirituality. William Osler used to call it faith. And family physicians sometimes may feel embarrassed about getting into an area that they have no expertise on. You don't need expertise. It's the patient's mind that you want to get into. Mm-hmm. And in palliative care, for instance, I see that as an area where the questions around spirituality, around faith, around purpose in life, around meaning, and around, what does life mean to you? What does death mean to you? And those sorts of questions that are related to quality of life. And their family physicians are dealing with it all the time. Mm-hmm. And if they want to study those areas, as the young researcher this morning did, he created a survey instrument and sent it out to family physicians in the Waterloo area and got an 89% response rate.
Wow.
And so this was a study that he's done, and he's now presented it here. And I'm sure that he's created a lot of questions that still need to be answered in those areas. So chronic disease, the fibromyalgias, the chronic fatigue syndrome, almost everybody over the age of 40 has a symptom, and it interferes with quality of life. And sometimes they don't feel that their family physician really understands because they look good, their blood tests are good, their blood pressure's fine. Mm-hmm. But I think that's where the research needs to be in developing ways for family physicians to get a good understanding of how people are suffering and how we can understand them, because often just validating that, following them on a regular basis and understanding that we don't necessarily need to be just following your blood sugars and your cholesterol. We need to get an understanding of what it is that's getting in the way of you enjoying life.
If you hadn't been a family medicine researcher or a physician, what would you have done?
I'm not sure. You know, my father was a laborer, and he taught me a lot about woodworking, and he built a number of cottages, and I watched him do that, and I was fascinated by it. And I also took piano lessons, and I enjoy music. I enjoy playing the piano. I married a flutist. I think that there probably are a number of areas that I could have enjoyed. I'm happy that my aunt pushed me into medicine.
Okay.
Because I wouldn't have thought about it.
Really?
That's right. I wouldn't have thought about it. But I've had feedback from patients and learners that have made me realize that I have some characteristics that some people feel better for after we've discussed their problems.
Very good. Thanks very much. It's been just a wonderful experience talking to you, hearing about your work.
Thank you.